test, the sing talk test, that puts you at moderate intensity, and that's been validated. So rather than telling patients, 50 to 70% of your max heart rate, use the sing talk test. Walk at an intensity high enough you couldn't sing while you're exercising, but not so high you couldn't talk. It shouldn't be uncomfortable. And that's a great way to do it.
Thank you. Hi, I'm Sidney Myers from Community Health. I'm the ACS coordinator for the region. And can you just briefly touch on a little bit more about the strength training versus that? I used to do HIIT until I got hurt. And so, and tried to do that next, but it'd be interesting to have a little bit more information.
Well, I'm telling you, as we age, and especially in women who lose about 10% of their lean muscle mass, we never hear about sarcopenia. All we hear about is osteopenia. Why? Because we got drugs for osteopenia, and suddenly it's the most important health risk we got out there. We're screening everybody with DEXAs. But sarcopenia is much more worrisome, I think, because it puts women at risk for falls. What do I care if the bone density is if you never fall and break your hip? What I really want is you to not fall. And we got great evidence that doing resistance training reverses and slows and reverses that sarcopenia, and then it reduces your risk for falls and hip and likely fractures as well. And so strength training for that and many other reasons, and it's interesting, the data looks almost exactly the same on strength training versus cardiovascular training in terms of lowering all those chronic diseases, from lowering blood pressure even to diabetes, heart disease. We got similar data showing the same kind of curve that strength training does. It's a great alternative. In fact, DC Lee, who's a good friend who did the running study, DC gives a talk called which would you rather be, the Hulk or the Flash? The fast runner or the build. And his conclusion, he presents great data. You're better off being Hulk. You're better off lifting weights for most of your life than doing cardiovascular exercise. But the better message is if you got a bad knee, you got a bad hip, do strength training. It's great for you.
And is that a one-to-one conversion, so to speak? If you're not going to walk, you just do your strength, it's a combination, or just strength training?
Absolutely. Doing it in sort of the same dosing range. 30 minutes of strength resistance training done at an intensity that gets you a little winded in that same range is probably will achieve it. But most of us would recommend 8 to 10 different muscle groups, working those in maybe 2 sets of 10 reps, done at 50 to 60% of your 1 rep max, kind of a good place to start. We're not looking for you to build big muscle, just to keep the muscle working and toned and reduce that sarcopenia that all of us get, just like osteopenia with age. We lose not only bone mass, but muscle mass, and trying to hold that in check is where you get the benefit.
Great. Dr. Harper?
Yeah, hi. John Harper from Kaiser in Sacramento. So I completely believe the data, but how much do you think there's an influence from a self-fulfilling prophecy in that maybe you've got people who are cardiac cripples and they can't exercise, and obviously their mortality in the short term is going to be much higher. Someone with horrible emphysema, they can't exercise. So they fall into that worst category, but they are at a much higher risk of mortality from their underlying disease.
Right.
So how much do you think that's an influence?
Yeah, so that's a very good point. These are the data I mostly presented are observational studies that don't necessarily prove causality. But I think when you have this much observational data, we also have evidence where you take an elderly patient and you put them on an exercise program and all of these health measures improve. I think it's hard to argue it from that standpoint that we're not seeing causality. It's hard to imagine. And we do a lot of things where we don't have definitive data. We just have observational data. There are a lot of things we do in medicine that just is supported by that.
Andy?
Yeah, so Andy with the American Heart Association, American Stroke Association, although this is probably dedicated more to myself. What about, a couple things first. You mentioned running and jogging, a believer in that, weight training, certainly a believer in that. What about swimming and biking and some of the other exercises? I know triathlons.
That's the beauty of exercise. It doesn't matter what formulation you take. They all work just as good. So we know that gardening vigorously, where you're a little bit winded, that sing talk test. I'm working, I'm hoeing, I'm pulling weeds, I'm a little out of breath. I couldn't sing because I'm out of breath, I'm sweaty a little bit. Gives the same benefit as jogging or going to the club and playing tennis. You don't have to go out and do a formal exercise. Working vigorously in the yard or in the house seems to give the same benefit. So it doesn't matter which formulation of exercise you take.
My second piece to that is quick bursts of exercise, intense, getting towards maybe more anaerobic. As you get older, you have to watch, obviously, right, we talked about risk factors.
Yeah, that's a great one. High intensity interval training, as I mentioned, I didn't have time to cover that, but I'm a huge believer in every study that comes out shows you get more benefit for the same amount of time, and you can get the same benefit in less time. And my good friend Marty Gabala has done a lot of this work, and Marty talks about, it's a relative high intensity. You don't have to kill yourself to get significantly more benefit. So what I do when I jog, I like to go street light to street light. I'll do maybe one street light run, kind of, intense pace, and then I back off for the next street light. And then run more on the next, that sort of interval. It's a relative increase in intensity. It doesn't have to be all out, drop dead, have to take a nitro intensity to get those benefits. So I think there's great merit there. But again, the evidence base there is not as robust as we have on just regular, moderate to vigorous physical activity.
So Dr. Kohatsu and then Dr. Herbert.
I have a question for Dr. Sidney. You showed really dramatic disparities by race, ethnicity, and gender. And as we think about either clinical or population-based interventions, can you comment on those disparities and what we should think about as we think about how to address them? Again, either at the patient level or at a population level. For example, how much is physiology, how much is social factors, or some combination?
That's a good question, and one could probably talk about that for many hours. But I would say there are certainly individual and genetic factors at work. More likely, so that's part of it. There's a great deal of social factors and what we call built environment, other factors having to do with socioeconomic status, the availability of good food, availability of places where you can exercise, for example.
Yeah.
And feel that you're safe doing that. But I think they all. These are huge disparities. So I think there is certainly part genetic, but I think these behavioral influences are huge. I do think, I'm very supportive of the role of physical activity. That's actually been my big go-to in my own life. I actually have a fair amount of coronary calcification to show for it, I guess. But I think the idea of looking at these, first of all, making a situation where you can have the opportunity to take advantage of life's simple set of things like having a good diet, being able to do regular physical activity, watching your blood pressure, have a reasonable, weight, and all of those things. Those are really important. We have huge amounts of societal work to do, and they have to do with the environment that people live in, grow up in, and not really being setups, because a lot of, as I'm sure you're all aware, people who below socioeconomic status tend to live in unhealthier areas. I mean, you're closer to a freeway, closer to things that are really bad for health. Stress is not good for us, and there's certainly a lot of situations that are highly stressful living situations. Air pollution, we are increasingly learning, is a significant risk factor for cardiovascular diseases. So that's not a real specific answer, but I think the answers are in many different dimensions. I do want to get back to the point, though, that to me, focuses on physical activity, which I think is huge on the behavioral aspect. On the risk factor aspect, to me, hypertension is probably the most overwhelming because it's really the most prevalent. It's 30% of the population with hypertension, 40% of African Americans. National rates of control are in the 50 to 60% range, though I think in a lot of our medical groups we do much better than that. But the thing about hypertension is it is a life course risk factor. The longer you have it, the more you're likely to get some of the worst outcomes you can imagine. And it's we know how to treat it. I mean, in the first line of treatment is certainly behavioral, lifestyle, and diet. But beyond that, we have good and relatively inexpensive drugs that have the potential to control most people. So, what's the answer to that?
You know, Steve, I'm always troubled by this discussion on social determinants of health, and this idea that your zip code is more important than your genetic code, and I get all that. But I think it clouds the issue because, in my simplistic look at it, social determinants of health are all about whether you have access to healthy food and places to exercise, and obviously you're not torn by from crime to drugs to excessive alcohol, those kind of things. And I think we could fix that. If we advocated more for getting rid of food deserts and giving people places to exercise rather than focusing on this income distribution, I just think that doesn't go anywhere. And I'm frustrated that we don't talk more about specifics on eliminating food deserts, because I think that's something we could do.
Yeah, no, I totally agree. If you can do something that does that, and makes people more likely to have good diets and
Be physically
I
active
totally
in
agree.
communities.
Yeah, places where you can go out and take a walk
Yeah.
and feel comfortable about it.
Excellent, Dr. Hurd.
The coronary artery calcification screening is an interesting technology. As far as either of you know, is there a population in which it's been shown that doing that screening actually lowers mortality? Which enables you to change therapy and bend the curve.
I am not aware that has been done. It makes sense.
Seems like we ought to do that study right before we start recommending it.
It's an expensive technology.
Yeah.
With a lot of downstream costs. And I'm not aware of one either, and it astounds me that people push it, yet we don't have that yet so basic data.
But at least we've gotten to the point where people are talking about pushing it more judiciously.
Yeah.
So it's not,
And Steve, do you know, what is the correlation? I get all these patients that get a chest x-ray, and they've got a calcified aorta, and I gotta code that, and how does that correlate with their coronary calcium score? When I see on a chest x-ray calcification in the aorta, does that automatically mean they've got a coronary calcium score over 100, or what does it mean?
No, I'm not sure I've seen that work, but it definitely wouldn't mean that if you have aortic calcification,
It's
you're
not
more
necessary.
likely to have.
Because we code that on every patient. We get paid more if I just put, and I'm recoding this every time, that they've got calcification in the aorta, and I never understood where's the evidence that that comes from.
I will tell you something interesting that maybe a lot of you haven't heard of, because one of my colleagues is doing a study of breast calcification. And that may well be correlated with coronary calcification. And he's actually doing, should have some data on that soon.
You haven't included that in the cardio study, the patients with aortic calcification or breast calcification? That'd be interesting.
No, but this is one where they have gotten several thousand women and measured breast calcification and looking at
On their mammograms and show.
Because we have some really old data from Kaiser going back to the 60s, where somehow they were doing all these what they call multi-basic exams and did hundreds of thousands of these, and they marked down a field for breast calcification. So breast artery calcification or breast calcification at all. And my colleague first of all looked at it and see if it was related to coronary events, and it was. So now really a much better studies being done of that. We should have an answer about that. And of course, the nice thing about that potentially is that most women have mammograms, and if you could pick up
Yeah.
calcium on that, if you do something about it, there's potential to be useful.
Interesting. Dr. Akbar.
Frank Apgar. Probably a different area. I wonder if there's a role to work with a younger population on a public health basis. When I went to junior high school and high school in California, we had PE classes 5 days a week. If there is a role for that, what would you do, what would you suggest to the State Department of Education, local school districts, as far as reinstituting PE classes? How often would they be? What's the minimum amount? Thinking in terms as well of you're generating a lifestyle to go into adulthood.
Yeah, I get that. I'm extremely frustrated that, you know, and it was interesting, it sort of correlated with, 15 years ago, we started pounding on sugary snacks and drinks, and we took those out of the vending machines. Everybody was going, yeah, that's good, we got those out, the kids are gonna be great now. And they took PE at the same time. And, sort of our generation, it happened on our watch as physicians and as school administrators, that we allowed this to happen with this stupid idea that we need more time to teach reading and writing and arithmetic. And yet we have this great data from California school districts looking at the correlation between fitness and standardized test scores. Direct correlation. Kids who are more fit score better on the standardized tests. And there's just no explanation that we've taken it out of the schools. And in fact, the PE that's there is so watered down that you can't even include that in reportable amounts of physical activity for kids, because it doesn't qualify to even be moderate intensity, certainly not vigorous intensity. Most of it's just standing around. And it's really a shame that that's been allowed to happen on our watch. And we in healthcare and other influential occupations perhaps could have spoke out against it, and we didn't. And I don't understand that. I think it's shameful that it happened on our watch, and here we are graduating kids that just, they're going on to E-teams now. That's become a sport, that they're on, video game teams and getting a letter for it. Like it's actually a sport that we should somehow aspire to. It's hard to imagine.
A point to that is, my son's in high school, the other, my daughter's graduate, is it also the fact that they're narrowing the scope of exercise? It's either you're on football, basketball, and you don't make the team, you don't make it, you're out. And then there's nothing. So I think that's part of the problem
Yeah.
nationally at the high school level, and then you better be in club.
And that's enough talk that I've given. What's amazing, while we've seen this explosion of obesity rates in kids being much less active, at the same time, I do clinical sports medicine, we've seen an explosion of overuse injuries, because we either got a kid on 4 travel teams and doing way too much, and another kid doing nothing. We've lost the middle group. You gotta be on the team, and you're and doing it, 150%, or you're not doing anything. It's a shame that we lost that middle group.
And I just want to say, I would go beyond that whole thing with physical activity. I've been trying to start to work with a school board member in my district about the whole issue of educating our children about all the things about Life Simple 7 and cardiovascular health and proper dieting, giving them skills in diet and, maybe cooking perhaps even, that go along with the same sort of thing you would do with physical activity. Because this whole idea, we know that cardiovascular disease is a lifelong disease. It starts when you're young, and if you do the right things when you're young, you're going to likely be very fine.
The data clearly shows that the kids who exercise when they're young, much more likely to turn into adults who do regular exercise.
And one other thing that we haven't talked about here at all, and I just wanted to put it out there, and a lot of you are aware of it, that dementia, which, as you know, is just an epidemic at this point in older folks, is some of the origins is neurologic, but a lot of it is cardiovascular risk. And we've shown in cardio, where we're doing cognitive function, way before people become demented, that all the things we think about, including physical inactivity, are risk factors for lower cognitive scoring decline, which presumably will translate into some people going on to cognitive decline and dementia.
Yeah, we've very clearly shown these studies with functional MRI, where they show the hippocampus grow. We lose 1% of hippocampus volume, and you put somebody in an exercise program, and all their cognitive scores get better, the hippocampus starts to grow. It's astounding how powerful a drug that exercise is to try to prevent and reverse dementia.
That was an excellent point. About a year ago, one of our sessions, we had someone here from Loma Linda, going over, the frequency of dementia is just.
Excellent. Dr. Hartman?
Question for Dr. Sidney, and this, you may not be able to answer it because this is looking,
There you go.
this is looking quite a bit into the past, but you started this study of something in young people, and the prevalence of what you're looking for was very low, right? I mean, you're looking at cardiovascular events in the population of very young adults. How did you get them to continue funding for so long with something that you have to prove each time you're going up?
Well, I would say, when it was originally designed, it was a contract from the National Heart, Lung, and Blood Institute. It was designed as a 5-year study. And, everybody knew it was not about looking for heart attacks or, anything even subclinical. It was looking at risk factors and how they change in young adults. With 2 exams over a 5-year period. And it's like a lot of other studies. This one, was pretty successful with it. At the end of 5 years, you kind of show what you've done, what you've learned, and if you get them interested enough, you get another 5 years. And it's never, I would say it's never trivial to get that 5 years of refunding at any point in time. Certainly can't guarantee it, and there's a lot of political things that happened. We were almost, the study was almost stopped, I think it was at 15 years. And it literally took, the head people from the scientific end of the study to go to the head of the institute to argue for why it should be continued. And that's what happened. But it's incremental, and that's really what it's all about, showing productivity.
Just briefly go back to the children that exercise. From a time perspective of amount of exercise, would that mirror what you presented today from the sedentary to the, just taking that first quartile? Would it be that same amount of time, or would you say children need to be more active than that?
They need to be more active than that. And in kids, the recommendation, the U.S. physical activity guidelines are for 60 minutes of moderate to vigorous physical activity, and half of that should be vigorous. And they also should involve bone strengthening and muscle strengthening exercise. So jumping, running, things that are pounding the bones, as well as pulling and climbing trees, doing tug of war, even lifting weights, that they should be doing both muscle and bone strengthening exercise. So it's a little beyond what certainly we recommend in adults. But I think you still kind of get that same curve with risk of disease and things. Just doing even part of the guidelines gives big benefit.
Thank you. This has been really interesting. I think I have an observation. My name is Mark Gary. I'm with HealthNet, and I've been involved since the inception of this RightCare initiative practices. I'm really sad there's not more people here, because I think that so much of our cardiovascular health presentations and educations to physicians or health practitioners has been really focused on middle age, to gerontology, to aging. And this issue that you brought up today is really well worth the room being full, with all of the people that have been involved over many, many years. And I think that our education, I manage health education for Northern California for HealthNet, but I've been involved for 30 years in public health here in Sacramento, working with most ethnically diverse populations, especially seniors. My background is gerontology, and I think so much of our educational literature that we put out and so much of the funding that goes to this issue is targeted at middle age to aging. So this has really opened up a whole opportunity, I think, by coming here today and speaking and sharing your message. And I really hope that the RightCare repeats this. I
Yeah,
know
well-
it's the holiday and it's that after a holiday, but it was really, really informative, so thank you.
Thank you.
This was outstanding. This is the one that, and I've been here, numerous times, and Hattie's never missed, and this is the one that she's back in Atlanta. And I would just suggest that this is just about as good as being there at the CDC as what she's getting. But we have it on video, and we'll do what we can to spread the word, and you can take what you have back to your colleagues. And it has been really phenomenal. You all have, in addition, on your desk, on the table, you have a lot of data on there, thanks to Brian and Megan and those who have put this together for you. We won't go through that. We don't have time for that. But if you would synthesize that a little bit on your own and see what that can help teach us. It has been really phenomenal. Before I close, though, we have time for another question, unless you covered it all. Is there anything else from our experts? Okay. All right. Well, Brian, can you show that slide? Speaking of Hattie being back in Atlanta, as you see here, Dr. Thompson, in this picture, as they're at the CDC, and they're looking at all of those various efforts nationwide that are being put forth for hypertension control. Right down here in the corner, we have RightCare Initiative, along with those other groups. And so that was exciting for us to see, and Hattie snapped a picture of it. And so lots of good work going on there, and we appreciate all you who have come and participated. It has been very worth it. This has been fantastic. Thanks to our speakers. We appreciate you all, and have a safe day. Bye-bye.
Nice to catch up with you.